Welcome, I'm Dr. Robert Glatter, medical advisor for Medscape Emergency Medicine. Joining me today is Dr. Sandeep Jahar, a practicing cardiologist and professor of medicine at Northwell Health, frequent New York Times op-ed contributor, and highly regarded author of the upcoming book, My Father's Brain, Life in the Shadow of Alzheimer's. We are here today to discuss the rationale for age competency exams for practicing physicians.
Thanks for having me.
Your recent op-ed piece in the New York Times caught my eye. In your piece, you referred to a 2020 study, or actually survey, in which almost a third of licensed doctors in the US were 60 years of age or older, up from a quarter in 2010. You also state that due to a 20% prevalence of mild cognitive impairment in persons older than 65, practicing physicians above this age should probably be screened by a battery of tests to ensure that their reasoning and cognitive abilities are intact. The title of the article was, How Would You Feel About a 100-Year-Old Doctor? So I want to ask you, Dr. Jahar, how would you envision such a process? What aspects of day-to-day functioning would the exams be truly evaluating?
A significant number of uh, uh, people over 65 have measurable cognitive impairment. By cognitive impairment, we're not talking about dementia. So the best estimates are that 1 out of 10 uh, people over age 65 have dementia, and roughly 1 out of 5 have what's called MCI, or mild cognitive impairment, which is, sort of cognitive impairment out of proportion to what you'd expect from normal aging. So it's a significant issue. The argument that I made in the op-ed is that uh, neurocognitive assessment is important. Um, that's not to say that everyone over age 65 has significant cognitive impairment, or older doctors can't practice medicine safely and effectively. They absolutely can. The question is that, do we leave neurocognitive assessment to physicians who may possibly be suffering from impairment? In dementia, people very often have impaired self-awareness, a condition called anosognosia, which is just a neurological term for you're not aware of your own impairment because of your impairment. I would argue that instead of having voluntary uh, neurocognitive screening, that it should be mandated. And the question is, how to do that effectively, um, fairly, transparently. One could argue a gerontocracy in medicine today, where there are so many older physicians. What do we do about that? That really is something that I think needs to be debated.
The question I have is, if we don't take care of this internally in terms of, physicians and the healthcare profession, someone's going to do it for us. We need to, jump on this now while we have the opportunity. And I think certainly the AMA has been, opposed to this, except when you have reason to suspect, cognitive decline or patient safety. A mandatory age of retirement is certainly something they're not for, and we know this.
Yeah.
But your argument in your op-ed piece is very well thought out. And I think you lay the groundwork for testing. I mean, looking at someone's memory, their coordination, their processing speed, other executive functions. And certainly for, say, a psychiatrist, hearing's important. And say a dermatologist, their vision's important. And for a surgeon, there's other issues. And, certainly based on your specialty, we have to be very careful to see what the important aspects of functioning are. And I would sure you agree with this.
Obviously, the sort of hand skills that are important for, ophthalmological surgery certainly aren't required for, office-based, psychological counseling, for example. So, we have to be smart about, how we assess impairment. You kind of describe the spectrum of actions, right? So there's, on the one hand, there's like mandatory retirement at the age of whatever, 65 or 70. I mean, we know that commercial pilots are mandated to essentially retire at the age of 65, and air traffic controllers at, in their late 50s. We know that there's a lot of variability in competence. There are internists in their 80s with whom I've worked, and I'm absolutely wowed by their experience, their judgment. Um, and there are new medical resident graduates who don't really seem to have the requisite level of competence that would make me feel comfortable to have them as my doctor or a doctor for a member of my family. So there's a lot of variability. So to mandate retirement, I think the AMA is absolutely right. To not call for any kind of competency testing, to me, seems equally unwise, because at the end of the day, you have to balance individual physician needs, or wants, the want to continue practicing, with patient safety. So I haven't really come across too many physicians who say there's absolutely no need for competency testing. So then we have to meet somewhere in the middle. The middle is either voluntary um, cognitive competency testing or mandatory. And I would argue that because we know that as the brain changes and we have cognitive impairment, that we're not always aware that we need help. I would say that mandatory testing is the way. And one other thing that you mentioned about, yeah, having the solution imposed on us. I mean, you and I are doctors. We deal with bureaucracy. We deal with poorly thought out solutions to issues in healthcare that make our lives that much more difficult. Um, I don't want that solution imposed on us by some outside agency. I think we need to figure this out within medicine and figure out the right way of doing it. And the AMA is on board with this. They haven't called for mandatory testing, but they have said that if testing were to occur, these are the guidelines. And the guidelines are fair and equitable, not too time consuming, transparent, not punitive. Like if someone comes out and doesn't test well, we don't we shouldn't force them out of the profession. We can find ways to use their experience to help train younger doctors, for example.
And I wanted to just kind of segue to an area that I guess there has been some challenge to the legality of these mandatory, types of age, restrictions, and also imposing the exams as well. The EEOC there's been a lawsuit as well, on behalf of, I believe it was Yale. And basically, there's been the concern that ageism here is part of what's going on. Yale actually now screens their providers beginning at age 70, and they have a program. UCSD has a program in place. And so obviously these institutions are looking at it, but this is a very small part of the overall picture. And healthcare systems overall, we're talking about a fraction of them in the country are really, addressing the issue of competency exams. So again, the question is, where do we go from here? How do we, get engagement or adoption and, truly get physicians as a whole to sort of embrace this concept?
So the EEOC filed a lawsuit on behalf of the Yale medical staff that argued that Yale's plan to do, I believe it's vision testing and neurocognitive screening. And there may be a physical exam also in that it constitutes age discrimination because it's reserved for doctors over the age of 70. Those are the physicians who are most likely to have cognitive impairment. I mean, we have rules already for impaired physicians who are, for example, addicted to illicit drugs or have alcohol abuse. We already have some of those measures in place. So this is really, it is focused on cognitive impairment in aging physicians because cognitive impairment is an issue that arises with aging. I mean, we have to just be clear about that. Most younger physicians will not have measurable cognitive impairment that would impair their ability to practice. And to force young physicians, physicians in their 40s, for example, to to undergo such screening, all in the name of sort of preventing age discrimination, just doesn't strike me as being a good use of resources. They're more likely to be false positives, as you know from Bayesian statistics. When you have low pretest probability, you're more likely to get false positives. And also, how are we going to screen, you know, all those hundreds of thousands of physicians? We have to make a choice about the group that really is more likely to benefit from such screening. Very few hospitals are addressing this issue, and it's going to become more and more important.
Absolutely. And as a medical specialty, surgeons have been particularly active in pushing for age-based screening. In 2016, the American College of Surgeons started at age 65 to 70, making surgeons undergo voluntary health and neurocognitive assessments. It also encouraged physicians to disclose any concerning findings as part of their professional obligation, which is pretty impressive in my mind. Um, so, I take that, surgeons, obviously, their skill set is quite demanding physically, technically, and as we both know. And I think that, in and of itself, that the Society of Surgical Chairs, took it upon themselves to institute this is pretty telling.
The overall society called for screening, but then in a separate survey of surgical chairs, the idea really was advanced that we should have mandatory retirement. Now, I don't particularly agree with that. I've seen it where you have the aging surgeon who was a star in their day, and no one wants to say anything when their skills have visibly degraded, and no one wants to be carry that torch and tell them that they need to retire. And so what happens is people sort of whisper, and then there are bad outcomes, and then we get involved. But unfortunately, bad outcomes have to occur before people tend to get involved, and that's what I'm trying to prevent.
Question is whether, older physicians have worse patient outcomes. The evidence is inconclusive, but studies have shown higher mortality rates for cardiovascular surgeons in terms of the procedures that they do. Um, but on the same flip side of this, there's also higher mortality rates for GI surgery performed by younger surgeons. So it's a mixed bag. And
Especially for specialized surgery, you need the accrual of a certain amount of experience. The optimal age is about 60, because they've seen a lot, they've seen complications, they don't have a hand tremor yet, I mean, so they're still functioning well, and they've accrued a lot of experience. So I think we just have to be smart about who we screen. There's a learning curve in surgery. So I'm by no means arguing that younger surgeons are better surgeons. But I would say that there's probably a tipping point where once you get past a certain age, and sort of physical deterioration starts to take effect, that can kind of overshadow the accrual of cognitive experience and sort of surgical experience. And so we have to sort of balance those things. Yeah, I would say neurocognitive screening is important. I would say vision testing is important. But then exactly what do you measure? Is how much of a hand tremor would constitute a risk? These things have to be figured out. But I just want doctors to be leading the charge here, and not have this imposed by bureaucrats.
It's interesting. I was reading that some doctors have had these exams administered, and they can really pass cognitive aspects of the exam, but only to then, there be nuances in actual practicing of medicine, day-to-day functioning, which they're not good at. And so someone made a comment in a piece about the only way to know if a doctor can actually do well in practice is to observe their practice, observe them taking care of patients. So in other words, you can sort of game the system, pass the cognitive exam in some form, but then have a problem practicing medicine.
I think ultimately it's outcomes that have to be measured. We can't adopt such a granular approach for every aging physician. I think there has to be some sort of screening that maybe raises a red flag, and then hospitals and department chairs need to then, sort of investigate further as, what are the outcomes? What are people saying in the operating room? Uh, uh, so, I think the screening is just that. It's a way of opening the door to sort of further, investigation, not a witch hunt. I have the highest respect for older physicians, and I learn from them honestly every day, especially in my field, cardiology, because some of the older physicians, I mean, they can hear things and see things on physical exams that I didn't even know existed. And I think there's a lot to be learned from them. So this is not intended to be some sort of witch hunt or try to, you know, get rid of older physicians, not by any means. We want to avoid some of the outcomes that I read about, in the New York Times, in the comments. That's not fair to our patients to not at least do some sort of screening to prevent those kinds of mistakes.
I wanted to go back to some of the data from Yale between October of 2016 and January of 2019. 141 Yale clinicians that ranged in age from 69 to 92 completed the assessments. These were, cognitive assessments. Of those, 18 or about 13% of those tested demonstrated cognitive deficits that were, quote, deemed likely to impair their ability to practice medicine independently. And that's telling. These are subtleties, but they're important to identify. And I think I would love to get your comment on that.
Yeah, I mean, it's in keeping with what we know about the proportion of our older citizens who have cognitive impairment. About 10% have dementia, and about 20% have at least mild cognitive impairment. So that's sort of in keeping with what we know. Um, and this was a general screening. There are certain programs, like at San Diego, for example, where physicians are referred, and so there's a selection bias. But here, this was just general screening. It's worrisome. Look, I'm an aging physician myself. I want fairness in this process because I'm going to be assessed as well. Um, but I just don't really understand yet why so much sort of circling of the wagons here and so much resistance. Um, it seems like it would be good for physicians also to be, removed from situations where they might get into, um, potential litigation, because of mistakes, because of impairment or physical impairment or visual impairment. So it seems like it'd be good for patients and physicians alike.
Right. I think it's difficult to give up your profession. There's no question to change fields or become administrative at some point, and when to make that transition. Because at some point, as we all get older, we're not going to have the ability to do what we did when we were 20s and 30s and so forth.
Right. I think a lot of the resistance is coming from doctors who are used to high levels of autonomy. And I'm certainly sympathetic to that because I don't want anyone telling me how to practice. Um, but the reason this is coming up and it hasn't come up in the past is not because of loss of autonomy, but because of an actual demographic change. You know, so many physicians were trained, um, in the 60s, 70s, 80s. They're getting to retirement age, but they're not retiring. And we can speculate as to why that is. In America's educational system, doctors incur a huge amount of debt. I mean, I know physicians who are still paying off their debt and they're in their 50s and 60s, so I'm very sympathetic to that. I'm not trying to force doctors out of practicing. I just want whoever's practicing to, be competent and to practice safely. We just have to figure out how to do that.
Right. And the fact that there is a shortage of physicians forecast, in the next 10 to 15 years, I think makes a lot of physicians reluctant to retire. They feel like they want to, be part of, that support network, that we don't want to have dire situation, especially in the rural areas. We're not immune from aging. We're human beings. And I think we all have to realize that.
I know that the ACC is starting to debate this issue, uh, in part because of my op-ed. My hope is that we'll start a conversation and we will institute a plan that comes from physicians and that serves our patients and doesn't serve some cottage industry of testing or or serve the needs of insurers or bureaucrats. It has to serve the doctor-patient relationship.
Some random surveys that I've read, up to 30 to low 40% range of physicians do support some type of age-based screening or competency assessment. The needle's moving. It's just not there yet, but I think that wider adoption is coming.
Yeah, I mean, I think that data is coming as more hospitals start to adopt these sort of late practitioner programs. But some of the data that came out of Yale, for example, is very important. I think we're going to see more published data in this area, and it'll clarify what we need to do and how big the problem is.
Well, I want to thank you again for your time. I thank you for writing the op-ed because it certainly, was well read, opened a lot of eyes of not just physicians, but the public at large. And I think it's a conversation that really has to be had. And thank you for doing this.
So thanks for inviting me, Robbie. It was a pleasure to talk to you.